The following podcast is part of a certified educational activity titled Harnessing the Power of the Latest Clinical and Research Advances in Small Cell Lung Cancer: How to Accelerate Progress and Improve Patient Outcomes with Current and Emerging Therapies. Access the entire activity and complete the post-test at peerview.com/ZZA860. Downloadable slides and practice aids are also available.
Welcome to this CME program, Harnessing the Power of the Latest Clinical and Research Advances in Small Cell Lung Cancer: How to Accelerate Progress and Improve Patient Outcomes with Current and Emerging Therapies. Today's faculty is listed on your screen. Taufik Owenikoko from University of Pittsburgh. I'm joined today and in planning this CME program by Dr. Hossein Bogai from Fox Chase, as well as Dr. An Cheng from Yale University School of Medicine. So our goals for today is going to be first to equip you with knowledge and skills to make the most of the current standard of care therapies available for patients with small cell lung cancer, and also to augment your awareness of emerging data on small cell lung cancer subtypes, as well as investigational therapies that have shown some promise in this disease. To get us going, I will provide some updates in terms of where we are currently with standard of care options for our patients, so making the most of current first-line treatment options for small cell lung cancer. So let's get going with how we get to where we are now and why we're doing what we do for our patients. So for this audience, well-informed, this is actually more of a reminder than anything new. Empower 133 study that tested atezolizumab with chemotherapy in patients with extensive stage disease, enrolled patients with measurable disease, good performance status, and required patients with asymptomatic brain metastasis to come on board, but they have to have that treated prior to enrollment. 403 patients randomized to standard of care, platinum, etoposide plus placebo as control, and then addition of atezolizumab to carboplatin and etoposide. See the stratification factors there by sex, ECOG performance status, and presence or absence of brain metastasis. With co-primary endpoint of overall survival and progression-free survival, these patients showed that the addition of atezolizumab to chemotherapy significantly improved the overall survival for patients, with hazard ratios shown there of 0.76, that was statistically significant, and that translated into improvements in median overall survival estimates of 12.3 months for those treated with chemo plus atezolizumab compared to patients treated with chemotherapy with placebo. Very mature data set as of the time of presentation, with median follow-up of 22.9 months. And this set the standard for us in terms of the use of atezolizumab and chemotherapy. At this year's World Lung, Dr. Stephen Liu presented the Umbrella A study, which is an extension study of the Empower 133. This was really taking patients who are more or less long-term survivors and then following them on after the study had closed and looking at what the outcome for those patients was. This is the long-term overall survival from this cohort of patients on the Umbrella A trial. Very small cohort of patients, but more importantly is that it gives us a very reliable data set of what the long-term outcome is with the addition of atezolizumab to chemotherapy. So now we have a benchmark in terms of 5-year overall survival of about 12%. Historically, when we talk to our patients, this number is usually around 3 to 4%. So while it's a modest improvement, is more than tripling of what we'll currently expect to happen to our patients if we just treated them with chemotherapy alone. And when we look at the site of progression on the Empower 133 study, as I mentioned before, patients were allowed to go on trial if they had treated brain metastasis, and we know that brain is one of the sites of failure of most of our therapies. Across the board, patients treated with atezolizumab compared to along with chemotherapy showed lower likelihood of progressing at every site that you looked at, and especially when you look at patients progressing in the adrenal gland. That is where you actually see dramatic improvement with the addition of atezolizumab. We've always known that small cell goes to the adrenal gland, We do not understand that biology, but this data is actually very, very interesting, showing that significant doubling of the rate of adrenal progression compared to patients treated with atezolizumab and chemotherapy. How about intracranial progression, another site of common site of disease progression? Patients treated with atezolizumab also had better intracranial control of disease, suggesting to us that not only do we have systemic benefit from immunotherapy added to chemotherapy, this also translated into better control of the disease in the brain. Whether this is a direct reflection of the antibody getting into the brain or stimulation of peripheral immune cells getting into the brain remains to be sorted out. But regardless, we are very, very glad to see this type of data showing that brain is not going to be a sanctuary site that you're not going to improve on when you treat patients with chemotherapy and immunotherapy. Switching gears to the other trial that also established another standard for us is the Caspian study, similar design to the Empower 133 with a few caveats. This allowed patients with untreated brain metastases if they were asymptomatic, allowed for the use of both carboplatin and cisplatin, and also included a third arm where you added tremelimumab to durvalumab, and then you had maintenance durvalumab post-treatment. Optional PCI was allowed for patients. This is the overall survival, 3-year overall survival update, also showing that this translated into durable improvement in overall survival when durvalumab was added to chemotherapy. Hazard ratio similar to what we saw with Empower 0.71 translated into median estimate of 12.9 months compared to 10.5 months. And with similar to the Empower study, the Caspian also showed benefit of this strategy in terms of brain control. Whether a patient had brain metastasis at baseline or not, there was improved outcome, both for OS especially, but also some trend with PFS when patients were treated with durvalumab and chemotherapy. So at the current time, we have these two established standards, at least here in the US. There are other regimens worldwide that have been developed and potentially also changing the standard of care in other parts of the world. I just want to quickly put this plug in for saplulumab, which was similarly designed to the Empower and the Caspian trial. This is actually an anti-PD-1, so that helps us to answer the question of, is it only anti-PD-L1 that works in small cell? So the addition of saplulumab to chemotherapy also outperformed chemotherapy plus placebo in this randomized double-blind phase 3 trial. Enrolled mostly in Asia. It's tantalizing to see that median overall survival estimate of 15.4 months and hazard ratio of 0.63 months. Whether this reflected the patient population or any unique activity of saplulumab, I think at this point it's just hypothesis generating and nothing that we can confirm. How about improving on what we currently have as standard? So if anti-PD-1, PD-L1 can improve on chemotherapy, perhaps layering on another checkpoint inhibitor will get us to where we want to be to raise that tail of the curve. And that was the rationale for conducting the Skyscraper-2, a phase 3 trial that added tiragolumab, an anti-TIGIT antibody, to atezolizumab and chemotherapy. Unfortunately, this study failed to meet its primary endpoint. Both for PFS as well as OS, there was really no daylight between those on the experimental arm compared to patient on the control arm. And while this was disappointing, I don't think it means the end of anti-TIGIT strategy in this disease. And in fact, we do have the KeyVibe 008, which is also testing a similar concept of adding an anti-TIGIT antibody to a backbone of chemotherapy plus anti-PD-1 or PD-L1. So we're going to wait for the result of the MK7684A, which is a co-formulation of the anti-TIGIT and pembrolizumab along with chemotherapy compared to atezolizumab with chemotherapy. So with that background and overview of where we are currently, let's consider a quick case and what we're going to do. 65-year-old man, past medical history of hypertension, COPD, and hyperlipidemia, heavy smoker with 45 pack year smoking history, came to the PCP complaining of cough, generalized fatigue for 3 months, good performance status. X-ray showed left upper lobe opacity. CT scan confirmed a 4-centimeter lobulated mass with associated hilar and mediastinal adenopathy. Patient was anemic and thrombocytopenic. Bronchoscopy and biopsy confirmed small cell lung cancer. No evidence of involvement in the brain. However, PET-CT scan did show evidence of hepatic hypodensities and extensive bone marrow uptake. Now in your clinic to discuss further management. Based on what we've discussed, for my faculty participants, I will invite you to weigh in. What would you recommend for these patients? Dr. Bogai?
Yeah, so the presence of anemia and thrombocytopenia is a little bit disturbing, obviously, perhaps suggesting some degree of bone marrow infiltration, which is unfortunately something we see with this disease. And if I remember correctly, in the old days, bone marrow biopsy was part of a staging system for small cell, but we've gotten away from that practice for good reason, really. So despite the fact that there is some anemia and thrombocytopenia, considering that this is metastatic small cell, I would probably still choose a standard treatment option with platinum etoposide, perhaps with some dose attenuation for both carboplatin and etoposide, which is what I use, with some growth factor support. And I still come in with one of the approved checkpoint inhibitors in this case, and monitor patient on a weekly basis with counts and support as much as needed for myelosuppression. I'm hoping that with that strategy, you can actually gradually recover some bone marrow function. Unfortunately, as we continue with the treatments, we know that's probably going to come back, but that's more of a treatment effect, not the disease.
I would agree with that. I'm on service this past week, and I've already seen this patient. So, these are folks that sometimes show up in the office. Actually, sometimes they show up in the hospital because they're very sick. And if they are in the hospital, somebody that we actually sometimes start chemotherapy in the hospital. So there are ways to get immunotherapy in the hospital as well. Our system hasn't necessarily figured that out yet, but certainly getting started with platinum doublet and adding on the immunotherapy, whether it's atezo or durvalumab, as soon as they get out of the office, it would be a standard approach. And agree with you, you might, if this is a frailer person, you might dose attenuate more and support them through. I think it's important to note that sometimes if you have a liver full of mets and the LFTs are very high, that you can actually also treat, and that will help especially if there's not other issues going on and you don't think there's obstruction, but it's really due to the disease, then you should really treat, and that will help.
Thank you. I do agree with both of you, and we're using this case to really illustrate the fact that between the two regimens that we have now, very difficult to choose between one or the other, but at times clinical features of the patient might lead us in one direction or the other. One strategy would be dose attenuation for carbo. If it's someone that we feel could be a cisplatin candidate as well because of the cytopenias, that could also be the way to go. But as we know, not many of our patients are eligible for cisplatin. So with that, thank you. I'll now hand it over to Dr. Cheng to take us through what we do for patients after they've progressed on frontline therapy.
We each have one. Okay. Great. Thanks for having me today. And I think that this is a disease where patients do very well, but unfortunately, we know that they're going to progress. And so this is, I think, where we need to make the most of our second-line options. And then Dr. Borgai will talk about other new options that are on the horizon. What data do we have in this? What recent data do we have in this to answer this question? And actually, there's a trial, phase 3 trial that came out, and it was published in 2020, and it was for patients 90 days out from their platinum doublet. They were re-challenged with either topotecan or combination chemotherapy platinum doublet. And so it was the trial was about 80 patients in each arm, and it was powered for PFS. And you can see the panel on the left shows you PFS, and there was a benefit for combination chemotherapy over topo. It was the PFS was about almost 5 months versus 3 months the hazard ratio of almost 6. And the overall survival benefit, there was no difference there. In terms of the toxicity, topotecan actually had more toxicity as expected around myelosuppression. So at least in this more recent data, showing that there might be a benefit to using combination chemo. If we look at the 2006 trial on the left panel that led ultimately to FDA approval of topotecan, that showed patients that were treated with topotecan versus best supportive care, and the overall response rate for topo is around 7%. Best supportive care was less. So this really, provided our rationale for using topotecan. The left panel is PO. The right panel is IV. It looks like there's a little bit benefit to the PO regimen. Actually, that's something that I used during COVID, much more for our second-line folks who wanted to stay out of the office and to have an oral therapy. Although it is still myelosuppressive, you can see that. Actually, you probably can't see that here, but on the left, the table is for PO, and then on the right, the toxicities for IV, and just as expected, really mainly myelosuppression, leukopenia, neutropenia, thrombocytopenia, anemia. So these are toxicities that you can support the patient through. You can dose reduce a little bit, but then we have growth factors and things to help with that, trilaciclib. So what other option do we have now? This is lurbinectin, which we're really excited because it's the second FDA-approved regimen that's approved for second line. And this is the rationale for use in small cell as a translationally active disease. So small cell is often characterized by P53 and RB loss, P53 mutations and RB loss, MYC amplification. And LURBI works in a number of different ways. It binds to DNA promoters, prevents transcription. That's what's seen in this area over here. LURBI is binding to the DNA, preventing transcription factors from binding. And that inhibits transcription and then affects a lot of different processes, including apoptosis, tumor proliferation, angiogenesis, immune suppression, that tumor microenvironment. And it also binding here, you can see that it's leading to RNA Pol II degradation. So there are a number of different methods and how it works. What we care about is the efficacy, and this is a trial. Here you can see all patients in this column. This is resistant disease, in other words, patients who relapsed within 90 days, and this is considered platinum sensitive longer than 90 days. And the PFS here is, this is what I tell my patients, the PFS is around 3.5. It's a little less for the platinum-resistant patients, and it's a little more than for the platinum-sensitive patients. And then here for overall survival, again, 9.3 months. It's a little bit less for the platinum-resistant, that's 5, and it's a little bit more for the, it's considerably more for the patients who are platinum-sensitive with 12 months. This, I think, is what we want to see for our patients. The duration of response in sensitive disease is around 6 months versus 5 months, and that's the swimmer's plot. So you can see patients that are on this for a while, and that's what I tell my patients. We're trying to, this is a marathon, so we want to develop different tools. So let's get you on some clinical trials, and Dr. Borgai is going to talk about those new agents, but sometimes in the interim, you have to bridge the patients. And this can be a very useful drug for that. The main side effects here, really the neutropenia, 20% grade 3 and 25% grade 4, and then fatigue, mainly grade 1 and 2, 50% of the patients. So it's pretty well tolerated. And so that, I think, is our standard of care. The phase 3 Atlantis trial came out, and we were a little disappointed because that was negative. This is a LURBI plus doxorubicin versus topo in the phase 3 setting. But if you look at the dose here with the doxorubicin, it was lowered. It was 2 milligrams per meter squared, as opposed to what you use in monotherapy, which is 3.2. I wanted to highlight this cohort of patients, 50 patients who actually, after 10 cycles of of treatment actually went to monotherapy with the higher dose of Lurbi. And if you look at the next slide, this shows you that in those patients, those 50 patients, if you had a PR, the 26 that had a PR, actually their best response on the monotherapy, 3 actually got a better response with a CR. 15 remained at a PR and 8 had progression. And in the stable disease cohort, 19 patients, again, 3 of those patients actually with the monotherapy had either a CR or a PR. So I think that's makes me think that maybe that dosage for the monotherapy, it's higher dosage, may have more of an effect. Okay, so this data has led to the NCCN recommendations for second-line therapy. If you have a chemo-free interval of 6 months or more, then the preferred regimen is either a clinical trial or retreatment with a platinum-based doublet. And there are other options, the lurbinectedin, if you have issues with, for example, the platinum, and of course topotecan, irinotecan, although I would probably not use those. If your chemo-free interval is less than 6 months, then again, the preferred regimen, clinical trial, lurbinectedin, as I spoke to you about, the overall response rates over there around 30%, a little bit lower for platinum-resistant disease in the 20s, and then a little bit higher for the patients who are in the platinum-sensitive disease around in the 40s or above. Topotecan, as I spoke to you about, irinotecan, or retreatment can be considered in that 3 to 6 months. That's a little bit of a gray area. And then we do have, in the literal gray area over here, other recommended regimens, including Nivo or Pembro if patients have not been previously treated with an immune checkpoint inhibitor. And we'll talk a little bit about how important it is to get patients exposed to some immunotherapy. Taxanes have been quite useful. I find in my practice, if they have CNS disease, sometimes trying Temodar. CAV, this was our comparator arm for all those trials with the platinum doublet. And I had a young gentleman, 45, who went on to a TROP2 trial, did quite well, and then Lurbi, and then a taxane, and was still working, right? And so I said, okay, he has a really great performance status, put him on CAV. He just got the scans last week and he responded very well. So that's still an effective regimen for patients who have a performance status and you think can still manage therapy. Okay, so piggybacking onto Dr. Owanakoko's case, his patient was successfully initiated on EP and Durva. He completed 4 cycles of induction chemotherapy with delays in initiating cycle 3 and 4 because of the delayed count recovery. He transitioned to durvalumab maintenance, and then the restaging scans after 7 cycles of monthly maintenance Durva unfortunately demonstrated multiple new or progressive hepatic lesions. The MRI of the brain shows 8 sub-centimeter parenchymal lesions consistent with metastases and without edema. He still has a good PS, and he wants to explore other therapeutic options. So Dr. Wanakoko and Dr. Borge, what would you recommend for this patient?
Yeah, so I think you don't ever go wrong by saying clinical trials, but then we don't have clinical trials in this room. So we have to recommend something else that's appropriate for the patient. So this is someone with polymetastatic disease, both in the brain and extracranially. Granted that they had very, very long chemotherapy-free interval, but for me, some of the factors that I take into consideration in terms of what I do for salvage is, how did they do with that frontline therapy? This was a patient where you had some delays in cycle 3 and cycle 4 of the frontline therapy. So I may not be as enthusiastic about re-challenging this patient with platinum doublet. The second is that you have this extensive disease in the brain that you also have to factor into. So you have to at least address that first. And right now we know we can do both SRS as well as whole brain radiation treatment. Some people will go up to 10 for SRS, and beyond that, they will offer whole brain radiation. But given the appearance and the size of the lesion, this may be a patient that most likely will fail much more quickly in the brain than anywhere else. And therefore, I may be veering more towards whole brain radiation therapy. So back to your question, I think this may be a patient where I do not want to do platinum re-challenge, even though they had a long chemotreatment-free interval, just because they struggled through that front line. And then the other option one would be, things like lurbinectedin and clinical trial if appropriate.
I agree. I think I would address the brain as well. And this is a very collaborative effort between the medical oncologist, the patient, and of course the radiation oncologist. I agree that we're pushing the envelope a little bit when it comes to SRS with brain, but 8 sub-centimeter lesions in a patient with metastatic small cell, I absolutely agree with you that it's going to cause more problems. So I think the whole brain should definitely be discussed despite all the difficulties that it has. I would say that here I will be a little bit more willing to retry the platinum etoposide. Remember, this patient has cytopenias to start with, which we thought were due to disease, so perhaps some of the earlier difficulties were related to that. Myelosuppression is something that we know can happen with different regimens. So given the 7 months period, I think, or 7 cycles, I'm a little bit more willing to consider the platinum etoposide, but at the side of the first real problem in terms of tolerability, I'm more than happy to go to lurbinectedin in that setting.
Yeah, exactly. I think I agree with both of you. Because he does have brain mets, I do think they need treatment. Lurbinectedin, that was a relatively small trial. They did not have brain mets. So I might think about I would probably do the platinum doublet again, just because I want to give them more time in terms of the tools that we use. But I would definitely put them on clinical trial if I had the choice. So excellent.
Would either one of you continue after whole brain radiation, just stay with the IO? Because there's no evidence of systemic progression, it's just CNS.
But he does have the liver. So, but I think that's a really good point. If they're on Durva or IO and they have oligoprogressive disease and we can radiate it, we do radiate it and try to continue and get a little more out of that IO. Good point. Okay.
I'm glad to see we all do stuff without data, but.
Actually, we do have one other alternative scenario. That's right. 70-year-old woman who presented with limited stage, and she was treated with platinum etoposide concurrent radiation. 4 months after completion of chemotherapy, so in that gray zone, she had 3 new liver mets that are approximately 1 centimeter each. The biopsy did demonstrate and confirm recurrence. She's asymptomatic. No clinical trial available today. What would you choose next? Dr. Borgai, what do you think of this? She hasn't had IO.
This is a tough one, right? Unfortunately, we see this in the clinic. So, I mean, this is something that happens. So I look at that 4 months after completion of platinum etoposide. And I'm not going to go into the discussion with 180 days and 90 days. So that's a totally separate discussion. But I'm saying this is 120 days from the last platinum etoposide, technically a little bit over the 90-day platinum sensitive resistant idea that we've seem to have settled on instead of the 180 days. So I would argue here that in the presence of liver metastases and the fact that I don't have a clinical trial option or anything like that, I would probably use platinum etoposide with an IO as a re-challenge. But this is a patient that I would be very worried about, meaning that probably right after the first couple of cycles, I will do another CAT scan, make sure that we have some sort of a response or disease stability, because I think this is unfortunately the patient who's going to have rapid progression, and therefore we're going to need to capture that. But I don't know if any of the other options right now are as attractive to me. And I have nothing against Lorbi in a setting like this, but I'm not sure that the trials necessarily include that patients like this. So that's the way I argue for it.
Dr. Wadakoko?
We put all these cases here just to show what we all deal with in the clinic. Our patients don't come well prepared with something that we can just give them simple answers. So this is a very, very complex one, but I do agree with Dr. Borgai. I think my own philosophy these days is none of our patients should go through their treatment course without some exposure to immunotherapy, given the potential for that to benefit them. So this patient technically will qualify for re-challenge, and because they've not been exposed to IO, I think that gives you the opportunity of chemo plus IO re-challenge. So that would be a reason for me to consider that as my first option of treatment.
Yeah, agree. This is a tricky one and it comes up all the time. But I do agree. I want to expose that patient to IO. They just went through platinum doublet. It's in that gray zone, the 3 to 6 months. So I think I would choose number 1 as well. But it doesn't mean that that's the right answer. We'll see with the patient. So thank you so much. I think that's my last slide. Yes, thank you.
Okay, so we're going to go into this evolving field. All right, so we've heard a lot about the biological subtypes of small cell lung cancer in recent meetings, and the data is still accumulating. This is a very fluid area, as you have seen in multiple meetings. What we think right now is that the differential expression of these transcription regulators can actually define, if you want, different subsets, although I think we're learning that these subsets are very fluid, meaning that with treatment, this is sort of a transitional state for some of the cancers that we're seeing. But 3 or 4 basic subtypes of non-small cell lung cancer have been identified through this differential expression of all the transcription factors, the ACL1, NeuroD1, and the PAU2F3. And they do seem to have different percentages in terms of the patient or tumors that have features that would classify them as ASCL1 or one of the other ones. Subtypes based on neuroendocrine features have also been sort of discussed, the A and the A, so the classical small cell, as we used to call it, versus sort of the non-neuroendocrine type of small cell. And this phenomenon of immune infiltrated or inflamed small cell lung cancer all are based on these transcriptional signatures. So the gene expression analysis has been in the background, and we've been trying to figure out if this can really be a biomarker for selecting patients for various treatments. So one of the really interesting retrospective data that has come out is looking at long-term survivors from IMpower 133 and looking at the gene expression profiling of these tumors, and sort of to come up with an idea as to whether some of these subtypes that can in fact translate to this long-term survivor. And this is one of the information that has been already published and sort of discussed at various meetings. So on the left-hand side, you have the gene expression heat maps, very familiar for those of you who've been in this area, looking at basically the 4 subtypes separated right on top. If you look at the Kaplan-Meier curves, on the right-hand side, so the blue curve, as you can see, is this sort of the inflamed small cell subtype. And there is, at least based on the retrospective data, there's an indication or a suggestion that perhaps this patient population is benefiting a bit more compared to the all other subtypes of small cell in terms of overall survival from this analysis. We also have, again, a similar analysis done with other subtypes, and you can see the hazard ratios by subtype on the bottom here. And even though the confidence intervals are really long, and some of them do cross one, probably because of the numbers here, again, the hazard ratio seen with I and maybe P seem to be a little bit more interesting. The question really is this something that we can use to select patients for specific treatments or not? And this is a sort of a bar graph. First of all, these are percentage of patients to look at enrichment for the long-term survivors in this patient population. So these trends, as we like to call them, of course, are non-significant, but in the atezo arm, 55% of patients were in the long-term survival group if they had the small cell inflamed subtype. And also a higher percentage of this particular subtype were in the long-term survivor versus none. Again, all these, is this an indication that this is a biomarker for us to select patients? I think obviously a lot more work needs to be done to really establish this as something we can use for patient selection. And again, I would sort of emphasize, as you saw in the hazard ratio curves on the forest plot, that the subtypes, all of them seem to have some benefit from the treatment. So Caspian, also looking at the Dura plus EP or the platinum doublet. And again here, something that is standing out is that this YAP1 positive, and I want to get into YAP1 a little bit later on in a couple of slides, also seem to be a subtype that could potentially have a significantly better outcome with the addition of a checkpoint inhibitor to platinum doublet based on, again, this rather small retrospective analysis. So this is published by Dr. Ruden's group. This has been published by Dr. Gay's group. And I think the YAP1 and the inflamed subtypes are probably the same subtype of tumors that we are discussing. So again, there is some data emerging that perhaps based on this molecular sub-analysis, we could identify potentially patients who would benefit from treatment. Now, keep in mind, these are all obviously first-line studies. We did not look at anything like this in the second line, at least based on what we have here. So patients with these, the other biomarker of interest is this, the inflamed signature, that if they have the higher expression, and I think we can get into the discussion as to how high versus low was defined in these particular studies, because we don't discuss that here. Again, there's a suggestion that that patient population is benefiting from the addition of immunotherapy to the platinum doublet. So what is YAP and what's the role that it plays in the small cell subtypes? And this is the data from Dr. Owonokoko's laboratory. So the hypothesis here is sort of shown in the bottom is the YAP1, a subtype that really stands out as having features that allow these tumors to be a little bit more inflamed and therefore possibly responsive to the immunotherapy. I don't think I'm going to go through the heat map analysis slide by slide, but I think the data there suggests that you can identify this particular subtype. So if you look at the clinical data, and here going back to Checkmate 032, which again, Dr. Owonokoko had presented, if I remember correctly, and PI'd, and this is an analysis done by Dr. Ruden's group. The progression-free survival, I have to say, if you're using Nivo alone, I think it's hard to say that there is really any separation. When you get to the P-Nivo, there's again a suggestion, as we like to call it, some sort of a trend towards possibly standing out as something that could suggest a slight benefit on the overall survival. Again, with Nivo alone, I think I have a hard time saying there's significant separation. I have to say with the Nivo Epi, one thing that's clear is that one subtype really doesn't seem to necessarily have a lot of advantage from all of this. So why YAP1? It appears for, again, mechanistically, I'm not sure we quite understand it, but tumors with YAP1 expression seem to have a better antigen presentation machinery in general, antigen presentation being interesting and essential for a good immune response. And therefore, the idea here is that the trend that we see with the YAP1 expression could, in fact, suggest that these tumors are more prone to a proper antigen presentation in the presence of a checkpoint inhibitor. The T cells can do a better job, and therefore that is the reason we're seeing this trend towards improvement in survival. Whether this really is going to stand out in further studies obviously needs to be determined, and also mechanistically, I'm not sure, again, we have an explanation as to what YAP1 necessarily does, but the immune infiltration signature is a little bit more expressed in the YAP1 positive tumors. So this data is going to percolate a little bit more. I'm sure we're going to see additional studies, and I'll be interested to see if my colleagues think this is ready for prime time, so to speak, meaning that are we ready to actually pull the trigger on a clinical trial where we would select patients for an immunotherapy type of approach in small cell lung cancer based on the inflamed or the YAP1 positive phenotype. So what else are we doing here? So some of you have seen the data with this particular agent. This is an anti-fucosyl GM1 antibody from BMS. This was taken into clinical trial, combining it with carboplatin etoposide and nivolumab, about 120 patients. There was some stratification based on liver metastases and ECOG performance status. Smaller study, phase 2, but appropriate size for a phase 2, I would say. There's a standard induction with sort of the 4-drug regimen versus probably what we would consider to be sort of more of a standard, although we all know that nivolumab hasn't been approved in this setting yet. And then the maintenance arm was, again, nivolumab alone versus the combination of the 9/6/12 drug in combination with nivolumab. The treatment was every 4 weeks. And as is appropriate for most phase 2s, the primary endpoint really here was more of a safety, tolerability, and PFS. I think we're going to sort of assess this once the data is available. We also have this prospective phase 1/2 study called the LUPER trial. So what is this one? This sort of takes advantage of the fact that lurbinectedin is an active drug, as we have seen based on the data that Dr. Chang already presented. There is as you saw, the mechanism of action for this particular drug. Besides its primary function, lurbinectedin does seem to have an effect on the tumor microenvironment, such that it might be able to alter the tumor microenvironment in a way that becomes a little bit more immune permissive as opposed to the typical immune suppressive microenvironment. And therefore, the idea here was, in conjunction with a checkpoint inhibitor like pembrolizumab, perhaps there could be clinical efficacy. Fairly standard inclusion-exclusion criteria, fairly standard dosing regimen, although slightly lower dose of lorbi was taken into this combination, which again, I think it makes sense. So there was a run-in for safety, followed by a dose expansion in a single-arm study. And the waterfall plots suggest that this is an interesting combination. The primary objective was met, as you see here, with a response rate of around 45-46%, which I think for a patient population that has had prior treatment, it makes this interesting, promising regimen. The median PFS, I still think, is pretty decent, 5 months. This is divided between platinum-resistant and platinum-sensitive patients down here. Again, there's no surprise. The platinum-sensitive patient population always does better, as we know, in terms of PFS in these studies. So again, I don't think there's necessarily any surprises here. The responses, as you can see on the waterfall plot, are seen regardless of whether patients had platinum-sensitive or resistant. What about safety? It always becomes a problem. So you see on the table here, the most common, really severe grade 3 or 4 toxicities were fatigue, neutropenia, and some nausea and anemia. I think fatigue, unfortunately, is very common for most of the treatments that we use in our patients with small cell lung cancer, or really any kind of lung cancer. And I think the neutropenia, nausea, and anemia is something that we have seen with lurbinectedin in other studies. So again, no real new safety signals that come out sort of being worrisome. So the main issue is that you have a very limited patient population. The real question is, can this be extended, and what happens if you take this to a larger patient population in a randomized study? So what are some of the ongoing studies? This is a confirmatory phase 3 study for lurbinectedin called the Lagoon trial. It's a rather large study, particularly for small cell, but 700 patients or so. Randomization to standard dose of lurbinectedin versus lorbi plus irinotecan, and basically a physician choice option that includes topotecan or irinotecan. The primary endpoint here is overall survival, secondarily looking at PFS and other factors, as you see on the slide. We also know that there is another trial called the IMforte study. This is a randomized phase 3 trial where the 4 cycles of induction is basically platinum etoposide plus atezolizumab. And then for patients who are not having any evidence of disease progression, there's randomization to atezo plus lurbinectedin versus atezo alone, and the study is still enrolling, and we're hoping that we can get there. Other interesting combinations are also being evaluated. We're not going to talk about PARP inhibitors really as part of this session, but that has been an area of interest. Some of the other trials that are underway are shown on this slide. So the NRG study, still underway, testing radiation, the role of thoracic radiation and radiation to metastatic sites while we're doing maintenance immunotherapy. I think that's a practice-informing study. As you heard, sometimes we continue the IO and radiate the progressive disease. The other one is we're still waiting for the results of the Adriatic, the Energy Alliance group, the LU005 study, and then a couple of other trials, hopefully establishing whether immunotherapy has a role in limited stage small cell, which is, again, something we haven't talked about. And then I don't know if you were at the session yesterday that Dr. Owanokoko was at, but there are up to 270 different trials in small cell. And 20 years of doing lung cancer, I don't think I've ever seen this many studies in lung cancer. I think that's important. So what else is coming? There's been a lot of interest generated, and again, full disclosure, I've been part of the clinical team that has worked with tarlatamab, so I don't want to sort of not be transparent and talk about that. There's been a lot of interest in BiTEs. So these are bispecific T-cell engagers. These are basically very small antibody structures that don't necessarily have an FC component. They are capable of targeting two different antigens. One usually is a CD3 to bring the T cells into the close proximity to a tumor by engaging through the other arm of this structure, a tumor antigen. The tumor antigen that's chosen in this case is DLL3, which is highly overexpressed in most small cell lung cancers. And the good thing about it is that, at least based on what we know now, there's either no expression or very little expression on normal tissue. So this basically generates what we used to call an immunological synapse to bring the immune system in close proximity to the T cell. The original formulation of these drugs had very, very short half-life because, again, it's a very small structure, but these half-life extended structures that now we have, they look more like antibodies that have a little bit better sort of circulatory time, and therefore you don't have to administer them on a continuous infusion. They can come in a variety of different structures, as you see here. One of the earlier one that has gone through a quite extensive clinical evaluation is the AMG 757, now called tarlatamab. So what you see on the slide is combined results of two separate studies. These are called Delphi. I don't know if I can explain to you where that name or acronym comes from, but it is what it is. So it has gone through a very extensive, I would say, phase 1 study and then a phase 2 looking at two separate doses of this antibody drug conjugate. I think if you concentrate on the phase 2 that was just presented at ESMO and then subsequently published by Dr. Pazarez and some of us on the panel, the two doses that were chosen were the 10 milligram dose and 100 milligram dose, and you see that the response rate are actually pretty good for a drug that's been taken into a patient population that's heavily pretreated with small cell. I think on the, I don't think we have the PFS or overall survival curves here. What is more impressive is that the durability of these responses are actually pretty good, which again, in the world of small cell, we really haven't seen. And given the fact that the two doses seem to be very similar, I think the 10 milligram dose is probably something that we're going to see for the development on. What about safety? Well, obviously, a drug that engages the immune system, you worry about immune-related adverse events, and in this case, the CRS events, the cytokine release syndrome has been observed. Majority of these are grades 1 and 2, but I would caution the grade 1, 2 CRS can still be serious, and if not diagnosed and mitigated, the patients could progress to higher grades. But overall, the safety profile of the agent seems to be good. So far, we've been doing this based on patients needing hospitalizations, but there are different cohorts now looking at whether we can get rid of the hospitalization with this particular agent, and I think we are making good progress. The other adverse events that we have seen with this particular agent are shown here. Some patients do experience fever, which could also be a sign of the CRS, but constipation, anemia, and a variety of other adverse events have been reported. In the interest of time, we're not going to cover all the other bites targeting DLL3, but you need to know that there are a couple of other agents, Boehringer Ingelheim, Harpoon. All of these agents are now undergoing clinical trial and evaluation. Some of them are at the earlier stage. And then interestingly, the DLL CAR T, and again, I thought one of these studies was discontinued, but I think there is still interest in evaluating that aspect of it. We also have antibody drug conjugates in the world of small cell. Again, many of these are in sort of earlier stages of development with small numbers. Interesting response rates and durability. So again, a lot of different clinical trials now looking at the antibody drug conjugate. An example of this is the IDXD drug, a very typical antibody drug conjugate with the toxin, antibody, and the linker there. And again, taking this into a clinical trial, the response rate in a limited number of patients across many different doses have been seen with a confirmed response rate of around 50% in about 21 patients, heavily pretreated. The other one that we have had some data for is actually TROP2, which again, it seems to be highly overexpressed in a variety of tumors, including high-grade neuroendocrine tumors. There are a couple of different antibody drug conjugates. The one that again has most data right now is sacituzumab, but a variety of other antibody drug conjugates are also being evaluated. In the interest of time, I think I'm going to bypass some of the results that have been presented. A lot of these have been discussed at various meetings. All right. I think with that, I thank you for your attention and thank you for spending early morning with us.
I want to thank all my co-speakers as well as the audience in person as well as online. Thank you all for joining us, and thanks to all the sponsors and PeerView for putting this together.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/ZZA860. This activity is supported by an independent educational grant from AstraZeneca.